Okay, so let's move on and talk about hemostasis, which is the process of what the body can do to stop bleeding wherever it's occurring. So whether it's in the skin from a laceration, in the gastrointestinal tract, anywhere where there's bleeding and the body wants to stop it. Okay, so there's been some kind of vascular injury at the top there. What happens first? Well, the body tries to vasoconstrict first. It'll locally vasoconstrict the arterioles and the capillaries to try and stop the bleeding. The next step is platelet activation to form that platelet plug, right? The platelets can very quickly respond when they're activated to aggregate at a damaged blood vessel and form a platelet plug. Okay, so we can call that primary hemostasis. Okay, there's also activation of the coagulation system, or what we can call the coagulation cascade. And the coagulation cascade is a series of proteins that we'll talk about, and the end result is a fibrin clot, a very strong fibrin clot that we could even call a scab, say, if it's on your skin, right? That's a fibrin clot. And that's secondary hemostasis, and that's much more definitive, okay? So vasoconstriction, platelet plug, activation of the coagulation cascade leading to a fibrin clot. And finally, what the body will do once the area is healed and the blood vessel has repaired itself, it can break down the fibrin clot, okay, by a process called fibrinolysis, which is the bottom right there. Okay, it uses a protein called plasmin that can actively break down the fibrin clot when the body's ready to break it down. Okay, and we all know that if you pick off a scab too early, it's going to start bleeding again. Okay, because the body wasn't ready to break it down. Okay, so these are all the components of hemostasis. Vasoconstriction, activation of platelets leading to a platelet plug, which is temporary. Activation of the coagulation cascade leading to a very strong fibrin clot. And finally, days later or a week later, fibrinolysis and clot breakdown because it's no longer needed. Okay, so why have a clotting system in our body? Well, without it, we'll bleed to death, right? There's just so many potential areas that could bleed or potential injuries that we can sustain that without a clotting system, we're going to potentially bleed to death. And that's why we have platelets, and that's why we have a coagulation system in order to stop bleeding, whether it's internal bleeding or external bleeding. What can go wrong with the clotting system? Well, it can clot excessively, and we've seen that in deep vein thromboses, pulmonary emboli. There can be excessive clotting, right? So, and that will result in conditions where we may need to use anticoagulants, and we'll talk about that. Okay, so actually we'll talk about it right now. Why do we use blood thinners such as warfarin or antiplatelet drugs? Well, we use them to try and prevent clotting or preventing a platelet plug from forming. So for example, someone who's had a stroke or a heart attack, well, we give them aspirin long term after they've recovered. Why? Because we don't want the platelets to form another platelet plug in the heart, say in the coronary artery, or in the brain, in the arteries of the brain, that can lead to another stroke. So we would use antiplatelet medications such as aspirin or other ones. There's one called clopidogrel that can keep the blood thin why would we ever use a fibrinolytic? So if you look at the slide before, you'll see in the bottom right that plasmin is actually a natural fibrinolytic in the body that will break down the fibrin clot when it's ready to be broken down. Well, we have very powerful fibrinolytics that do the exact same thing. They break down the fibrin clot. When would we ever want to do this? Only in emergency conditions where there's an acute clot that's formed in a coronary artery that's leading to a heart attack, or in an acute ischemic stroke. So a clogged artery from a blood clot that's leading to a stroke, and we can use a fibrinolytic to try and force the clotted blood to break down, okay, and open up the blood vessel as quickly as possible. And an example of that is TPA, and TPA stands for tissue plasminogen activator. So what does it do? Well, it's a drug that converts plasminogen, which is inactive in the blood, to plasmin. And if you look at the previous slide, you'll see that plasmin can actively break down a fibrin clot. Well, that's what we want to do in a heart attack, in an acute heart attack, that is, or an acute stroke. We want to break down the fibrin clot that's occurred, and we'll use fibrinolytics. What are the adverse effects of fibrinolytic? Well, we can make someone bleed severely elsewhere in the body, okay? Because it's actually affecting the whole body. It's breaking down any other fibrin clot in the body. So we wouldn't use a fibrinolytic for a heart attack or a stroke if someone also had, say, gastrointestinal bleeding, because it would make it much, much worse. And that's why we go through a series of questions before using an emergent drug such as TPA. We go through a series of questions to see if there's any chance that this person could bleed from another condition that they have currently. For example, say they had recent surgery. Say they had some gastrointestinal bleeding. We wouldn't use TPA because it's going to magnify the bleeding that they have. Okay, so in the interest of time, I'm going to leave this slide to you. We've gone through these steps. Blood vessel vasoconstriction, platelet activation leading to a platelet plug, activation of the coagulation system. The coagulation system can now form a very strong fibrin clot. And then finally, days to weeks later, the body can activate plasminogen to plasmin to gradually break down the fibrin clot. Okay, so this is just a really nice visual of showing you what's happening when a blood vessel is injured and it's leaking blood. So there's red blood cells leaking out in the top left part of this slide. And what happens? Well, exactly what happens on the right. There's been an injury that leads to a vasoconstriction locally of that blood vessel to stop the bleeding. And then finally, because the vessel's been injured, there's going to be an initial platelet plug, right? The platelets are activated. And then finally, the coagulation system kicks in and forms a fantastically strong fibrin clot to close up that blood vessel, okay? So really, normal blood hemostasis requires platelets and it requires the coagulation system combined. And if you look at the bottom left, you can see that there's red blood cells that are mixed with platelets that are forming that platelet plug. And then all around it, you have these powerful fibrin strands holding everything together tightly. Okay, another image on the same type of information, but let's just look at the clotting factor part. Okay, so yes, there's a blood vessel injury on the left there. Yes, there's activated platelets that are forming a platelet plug, but there's also going to be activation of clotting factors due to this injured blood vessel. And there's going to be a series of clotting factors that are going to result in a final pathway where fibrinogen, which is just a protein circulating in your bloodstream, it's not active, and as a final pathway, thrombin, which again is just a protein, and it's going to function as an enzyme here to convert fibrinogen to fibrin. And fibrin is that insoluble clot on the blood vessel that's mixed with the platelets and the red blood cells, forming that very strong fibrin clot. So it's a fantastic system that we have to stop us from bleeding to death. Okay, so so think of the platelets as the initial cells coming in, and then this activation of the coagulation system. Okay, so this is a very similar slide. Okay, top left, some kind of vessel injury, whether it's in your skin where you've cut your skin, whether it's in the gastrointestinal tract where you have a bleeding ulcer. The same process is going to try and stop the bleeding. There's going to be vasoconstriction of the local blood vessels to stop the leaking of the blood. And the injury to the vessel is going to release activating factors for platelets and activating factors for the coagulation system to try and stop this bleeding. And the first cells to plug up the damaged vessel will be platelets. And a bit later on, the activation of clotting factors will come in and form that fibrin clot. Okay? Now, when we're talking about the coagulation system, which is coming up, warfarin is going to be an important drug where we can inhibit the coagulation system. Warfarin acts on clotting factors that need vitamin K for their production. Okay? So when someone takes warfarin, it's actually inhibiting the production of vitamin K dependent clotting factors in the liver. So when the liver stops making certain clotting factors because of warfarin, well, the coagulation system just isn't going to be very effective. It's not going to produce a fibrin clot as quickly, right? And that's why we use warfarin as an anticoagulant, to inhibit production of certain clotting factors that will then slow down the production of a fibrin clot. And that's why patients on warfarin can bleed tremendously. Okay, say they've had a fall and they've hit their head, they can bleed into their brain much more easily because the coagulation system has been affected and inhibited by warfarin. Okay, so let's just look at the coagulation cascade and try not to feel overwhelmed by this system. Get the big picture, okay? So the coagulation cascade is really just a series of proteins that we've numbered. And you can see the numbers there in the two different systems. And both systems are in the coagulation cascade, the intrinsic system and the extrinsic system. And they all come to a common pathway. And what's the purpose of that common pathway in the end? Formation of a fibrin clot. Okay? So we can inhibit certain parts of these pathways with different drugs. I mentioned warfarin. Well, warfarin happens to inhibit factors or inhibit the production of factors in the liver 2, 7, 9, and 10. I don't think you need to memorize that. I'm just giving you an example of how warfarin affects the coagulation system. Okay, so what's the intrinsic pathway? Well, something that's just injured the inside of the blood vessel. So say there's a some kind of internal injury to the endothelial lining, such as say someone had a plaque in their coronary artery, and the plaque broke open and fat is now exposed to the bloodstream that's flowing by. Well, the intrinsic system is going to clot that up. It doesn't want to see it there. Okay, so it's going to see it as foreign and clot it up. So intrinsic injury to the blood vessel. What's the extrinsic pathway? Well, there's been some kind of tissue injury. So the blood vessel's been cut open, or it's been severely damaged or crushed, and it's activated the extrinsic pathway. Okay, so either one of these pathways can lead to the common pathway and finally formation of a fibrin clot. Okay, notice that you need calcium in the coagulation system. You may have come across this in the past, that calcium has all these other functions. Calcium is actually also needed in the clotting cascade. Okay, so let's continue talking about the coagulation cascade and the two arms that can activate the coagulation cascade. So we spoke about the intrinsic pathway, which is usually surface contact or injury of the endothelial lining, and the extrinsic pathway, which is usually a vessel injury and exposure of tissue that activates this particular pathway. Okay, and so you might ask yourself, well, why are these two pathways? Why did the body do this? Well, the intrinsic pathway is where there's been some kind of a vessel injury on the inside. So say it's from atherosclerosis, and now that atherosclerotic plaque has ruptured, and the coagulation system now wants to clot it because it sees it as foreign and it wants to heal it. Okay, which isn't necessarily good, because that's going to lead to more blockage of a vessel. Okay, so it's not always a good thing, but for the most part, the coagulation cascade is a very good thing. It protects you from ongoing bleeding and hemorrhaging. Okay, what about the extrinsic pathway? Well, that's a faster system. Look how short it is for the tissue factor on the right to activate factor 7, and then get directly down close to get to the common pathway in order to form a fibrin clot. So extrinsic injury to a blood vessel really activates the system quickly. Okay. Now, when we're talking about some common anticoagulants, okay, the intrinsic pathway is inhibited by heparins and low molecular weight heparins. Okay, and we use these drugs to purposely inhibit the intrinsic pathway to slow down clotting, right? So we could use heparin or low molecular weight heparin with a deep vein thrombosis or a pulmonary embolus, okay, to inhibit further clotting. Okay, what about an example on the extrinsic pathway? Well, that would be warfarin. And notice they don't mention warfarin on the left, but it's actually the vitamin K antagonist, right? So that's really the only one that we're going to talk about when you hear about the word vitamin K antagonist. Okay, and it inhibits the extrinsic pathway. So how are we going to monitor whether we're giving someone heparin, or we're giving someone warfarin. Well, with heparin in the intrinsic pathway, we use a blood test called a PTT. And we'll get into this in a bit more detail in the coming slides. So a partial thromboplastin time. And that gives us an idea of how much we're thinning the blood with IV heparin. Okay. What about the extrinsic pathway and warfarin? Well, warfarin, we can use a PT, a prothrombin time. Okay. Now, over the past 10 to 15 years, we've started to go away from using a PT to monitor how much effect warfarin is having on the coagulation system. And we use another blood test called an INR, International Normalized Ratio. And the reason that was done is so that a PT in one lab is very comparable to a PT in another lab, no matter where you are in the world. Okay, so that's why we use INR. And an INR, typically on someone who's not on any anticoagulants, is 1. Okay, so we've just chosen the number 1 as a normal INR. When you're on warfarin for, say, a pulmonary embolus or a deep vein thrombosis or atrial fibrillation, we usually like to see the blood thinned to an INR of 2 to 3, so between 2 and 3. Okay, and the higher the INR, the thinner the blood. Okay, so what can we do for someone who has an INR of 5, which is definitely too thin? Well, we can give them a dose of vitamin K. Okay, and this will allow the liver to start making some of those clotting factors, and it will improve the INR. It will lower it back to a level where we want it. Okay, so just think of heparin. So IV heparin, we monitor it with a PTT. Oral warfarin, we monitor with an INR, and the old way of monitoring it was a PT. Okay. The other thing I want you to remember is all these clotting factors come from the liver. So if you have liver disease, and we're not talking about anticoagulants right now, but if you have liver disease or liver failure, these clotting factors aren't going to be produced, and we can expect that your PT or your INR or your PTT will be elevated in your bloodstream, right? You won't clot as well because the clotting factors are absent. Okay. Now, recently, we've come to use inhibitors such as direct thrombin inhibitors, and you'll hear about these later, and factor Xa inhibitors. So why did we do this? Well, they don't require any monitoring. Okay, so we can give someone a factor X inhibitor, and because it's been studied in a lab at a fixed dose, it doesn't require any monitoring. So it makes it much easier for the patient instead of using warfarin. Since when you're on warfarin, you have to go for regular INR testing, okay, to make sure your blood doesn't get too thin. So factor Xa inhibitors and direct thrombin inhibitors, there's no monitoring of those, and they effectively inhibit the coagulation cascade, and we use them for DVTs, for PEs, and for atrial fibrillation. Okay. Now, the one thing I didn't mention is low molecular weight heparins. Well, those are injectable heparins that we use instead of intravenous heparin. they are much easier to use. Okay, so they're typically given once or twice a day. They're based on the patient's weight, and the other advantage, they don't require monitoring. Okay, so we don't need to do um, uh, ongoing monitoring of low molecular weight heparins, which is why they were partly produced instead of heparin. And you can see with the factor 10A and the direct thrombin inhibitors, there's no monitoring for those either. So really the monitoring is for intravenous heparin and oral warfarin.